So without further ado, cryotherapy for preventing chemotherapy-induced neuropathy, proven, promising appearing, or hogwash with Charles L. Loprinzi, MD. And let me say a few things before we meet Dr. Loprinzi. I will say that in our various lecture series, we often discuss side effects of numerous types of chemotherapy. Typically, these side effects appear as numbers, tables, charts. Now, of course, we know that side effects are much more than just a collection of numbers. They impact the way patients feel, not just during treatment, but sometimes for years, and sometimes these side effects can last a lifetime. And this is why the work of today's guest is so important. Dr. Loprinzi is recognized as a global expert in controlling symptoms related to cancer and cancer treatment. He is a medical oncologist whose primary research interest for more than 25 years has related to symptom control in clinical trials devoted to the treatment, prevention, and better understanding of untoward symptoms that are related to cancer, cancer treatment, or both. Dr. Loprinzi has led a group that has conducted well over 100 symptom-controlled trials, most of them placebo-controlled trials. This work has addressed the management of mouth sores or inflammation of the esophagus or bowels, cancer-related loss of appetite, weight, or both, chemotherapy-induced hot flashes, skin toxicity, sexuality symptoms, numbness, tingling, pain, or a combination, arm swelling, cognitive dysfunction, bone thinning, insomnia, and fatigue. His primary clinical interest is breast cancer, and thus many of the trials he has conducted relate to this area. Arguably, Dr. Loprinzi has been at the heart of defining more treatment approaches for uncontrolled symptoms in patients with cancer than any other individual over the past 3 decades. Dr. Loprinzi, welcome. Thank you so much for being here today. Dr. Loprinzi, what's one thing that we should know about you outside of this, this incredibly impressive background that you have in this field?
I'm one of 10 children with 11 and a half years top to bottom, no twins. Usually say 9 too many, and I do almost everything my wife tells me to do.
Wow, that's impressive. So with that background, sounds like getting along well with others should not be an issue.
I give it my best.
All right. So our first question, we mentioned poll everywhere. What symptoms are involved with chemotherapy-induced peripheral neuropathy? A, pain, tingling, burning, or numbness. B, sensitivity to hot or cold. C, difficulty with fine motor skills. D, all of the above. That's just a screenshot, and you should have access to that in just a moment for our audience. While you're looking at that, I will say this activity has been planned and implemented under the sole supervision of the course directors in association with the UNC Office of Continuing Professional Development. William A. Wood and MD, MPH, and CPD staff have no relevant financial relationships with commercial interests as defined by the ACCME. Greensboro Area Health Education Center is approved as a provider of nursing continuing professional development by the North Carolina Nurses Association, an accredited approver by the American Nurses Credentialing Centers Commission on Accreditation. Dr. Charles Loprinzi has relevant financial relationships with Pled Pharma, Disarm Therapeutics, Asahi Kasei, Metis Pharmaceuticals, NK Max, Novartis, Osmol Therapeutics, Neurobio, Hangrui Medicines, OnQuality, and Mitsubishi Tanabe. These relationships have been mitigated and have not influenced the planning or implementation of this activity. All right, we're getting a strong showing in our poll everywhere poll. We seem to be very focused on D, Dr. Loprinzi. How are they doing?
100% correct.
Great. And with that, I will turn things over to you.
All right. So happy to be here and to talk about chemotherapy-induced neuropathy and cryotherapy. So if again, the financial interest, virtually all I discussed will be off-label for this, and the financial things have not influenced this talk. So I'll start off by saying something that everybody understands, that CIPN, chemotherapy-induced peripheral neuropathy, is a major clinical problem. I'm going to be talking a lot during this presentation, or utilizing a lot during this presentation, the ASCO guidelines, which were published in 2020. This was actually a guideline update that had been published about 2016 for the first time, and then 2020 they were updated regarding to the prevention and management of chemotherapy-induced peripheral neuropathy in survivors of adult cancers. And oops, let me see if I can better get to my slides here there. So, all right, so I'll start off by talking about what approaches are recommended for prevention of chemotherapy-induced neuropathies. So not treatment of people who already have it, but when you're about to give chemotherapy that can cause neuropathy, what ways do we have of preventing the chemotherapy-induced neuropathy? And which of the following can be recommended for preventing chemotherapy-induced peripheral neuropathy? And acetyl L-carnitine, calcium and magnesium, gabapentin, and none of the above. And I'll wait for a little bit longer as people are weighing in on this. Okay, it looks like we're fairly stabilized with about 50% of people getting the correct answer. None of the above is the correct answer on this particular one, and I'll go into more detail on that in the following slides here. So the first recommendation with regards to prevention of chemotherapy-induced peripheral neuropathy is to talk to the patient. Well, I mean, there is one good way of preventing chemotherapy-induced peripheral neuropathy, and that is not to give the agent that causes the problem. It's not a good answer because we want to use the agent to try to kill off cancer cells, but that is the one way that we do know how to do it. But when a patient is going to get an agent, such as paclitaxel or oxaliplatin, and those drugs are the two most common drugs in practice that actually cause this particular problem. There are others such as vincristine and bortezomib and all. But the physician who's thinking about giving these drugs needs to talk to the patient. Does the patient have any underlying neuropathy? Do they have diabetic neuropathy or some other sort of neuropathy? Or do they have a family history that predisposes to neuropathy, a hereditary family syndrome? Because those can be important issues. And if a person's got fairly prominent neuropathy and you're thinking about giving paclitaxel for treating breast cancer, you might think about using another drug instead of that. There are some chemotherapy agents that do not cause neuropathy. Now, we think that the agents that we usually use for the breast cancer situation there are the best ones, and paclitaxel is in that category. But at times, you need to keep in perspective the neuropathy issue so that you bring that into bay as you think about it. So a recommendation made by the ASPR Guideline Committee was that acetyl L-carnitine should not be offered. It should actually be discouraged in this setting. And the reason for that is that there was a clinical trial that looked at acetyl L-carnitine in a placebo-controlled manner, and the acetyl L-carnitine group did worse than did the placebo group. So that's why the ASPR guidelines came out to specifically say this is something that we should not want to do in this particular setting. So the next recommendation talked about is this one, section recommendation 1.4, and they're not necessarily in order, but I changed the order a bit for this presentation here. And there's a long list of agents that should not be recommended to be given to patients in this setting. And these are drugs that are on that list of no recommendation. These are drugs that have been studied in a number of clinical trials, and some of them 2 or 3 trials have looked at them. Calcium, magnesium, keep that in mind because we'll talk about that a bit later on. But these are a lot of other things that have been looked at and were not shown to be beneficial. So it's not for a lack of people not trying. The guideline then went on to talk about other things, and these are things that we listed as could not be recommended to try to prevent chemotherapy-induced peripheral neuropathy outside of a clinical trial. That doesn't mean that it's wrong to use them or that you can't use them. This is actually a list of things that are a bit more promising than the last list that I showed you. And on the last list I showed you, there's possibly something in there that if another study could be done that might show that it's beneficial, but but it didn't look promising at all. These things look more promising. Acupuncture is one of the things that makes this list. There actually is no good evidence in here for using this as treatment, as prevention of neuropathy. It might be helpful for treatment of neuropathy down the line, but although not proven. Exercise is another thing that was on this particular list. There is information from a trial of patients who were randomized to get exercise versus not. They were randomized to get the exercise versus not for trying to improve fatigue symptom there, but they were getting neurotoxic chemotherapy, and somebody went back and looked afterwards and suggested that the people who got the exercise had less neuropathy than the people who did not get the exercise. It was not the primary endpoint. There is a NCI approved concept to proceed with a prospective trial looking at exercise versus not in that particular setting. So no proof of it being helpful. It's actually not a bad thing to do for people in general, so it's not a bad idea, and it might be somewhat helpful. I had an uncle who had a weightlifting gym, and he had a saying in his gym that said, and way back, this was decades ago when this was around, it probably should have said he or she, that would be the appropriate way now, but it said, he who could not find time for exercise must find time for illness, and I keep that in mind to try to make me do some exercise. Next thing here is GM1, ganglioside monosialic acid, and that is because there is a trial that looked quite promising, and I'll explain it here a bit. This is a trial that was done in China. It was looking at patients getting taxane therapy. Most of them got docetaxel as opposed to paclitaxel, and docetaxel does not cause quite as much neuropathy as does paclitaxel. And they were randomized to get the GM1 versus not. And the placebo arm is shown here in the dotted line here, and down is bad. They start off with a score of here, and this scale going down is bad, so they got neuropathy here, versus the group who got the GM1 did not get any suggestion of neuropathy. Now there's something that's kind of peculiar here, and that is that the people, after they stopped the chemotherapy, they had got 4 cycles of chemotherapy here, they then, when they looked at them 3 months later, the neuropathy had totally disappeared. And that's not something we see in the United States here. We actually usually see that it gets better, but the curve would probably be something like this sort of thing. So it's still not as good as it was at baseline, but in this setting, it got totally better. So this is a promising appearing product here. I happened to get word of it early on because I was asked to write an editorial regarding it. And then was able to talk with the company, and we have proceeded to develop a clinical protocol. It's been approved by the National Cancer Institute as an alliance clinical protocol. It will take patients receiving paclitaxel adjuvant therapy for breast cancer, and it will randomize them to get GM1 versus placebo, and we hopefully will have that open over the next couple of months. And hopefully then see whether or not there's better information to suggest that this is a good approach for these patients. And then next, cryotherapy and compression, something that is on the title of things, that we haven't talked about that so far, but we're going to start talking about that. And so question here, randomized data has supported the use of cryotherapy for preventing which of the following chemotherapy-induced conditions? Alopecia or hair loss, 5-FU-induced mucositis, onychomycosis, which is actually fingernail damage. Some chemotherapy drugs can, such as docetaxel, can cause a lot of damage to fingernails while you get it. Okay, so it looks like we've got things fairly set up with alopecia being the top pick, all of the above coming at second at 38% in onychomycosis. And the answer is that all of the above, there are data on all of the above suggesting that it's useful in this particular setting. So alopecia prevention, we'll start off there. And 3 questions for me to address in the next couple of slides. First, When was the first published report that suggested that scalp cryotherapy was helpful for decreasing chemotherapy-induced alopecia? And everybody think of what answer you would give here as you jot it down on your own piece of paper if you can. Second, when were the convincing trials published that made scalp cryotherapy relatively common? Jot that down too. And then do some addition or subtraction, How many years did such take between the time when it was first suggested in print versus when it was well established? And this is a review article that was written by Kunal Kadakia, who was a resident at the time, talking about supportive cryotherapy, a review from head to toe. And he did such a good job on this manuscript that when it was submitted for publication, not one recommendation was made on the manuscript, which is not a common sort of thing at all. But the first report on cryotherapy in the literature was 1973. And some of us were not very old then, and some of the people in the room maybe were not even born at that time. And as of 2013, when this article was printed, there had been over 59 non-randomized reports regarding scalp cryotherapy, and there had been 7 randomized trial reports that had come about. In 2017 is when there were 2 published papers in JAMA, not published at the same time, but both that year, which really demonstrated that a way of giving scalp cryotherapy, either with Pachman or Dignitana sort of methodologies, was fairly well established, and that has become relatively well established in a number of practices around in the country and around the world. Europe was quicker to bring this up than we were. So if you got your answers right, you would have come up with 44 years that it took for cryotherapy for alopecia from the first report to when it was established. So people are talking about cryotherapy for preventing neuropathy, and some people are thinking that it works, and how come it's been going on for some time, and how come we don't know? We hope it doesn't take 44 years, but it will take some time to sort that out. So 5FU-induced mucositis prevention. So when I was relatively early in my academic career here, we started to do symptom control trials. Nobody else was doing them per se. And we did a trial looking at a way to try to prevent 5FU-induced mucositis with the allopurinol mouthwash, because people thought that was helpful. And the people who had come up with that had actually looked at the 6 patients who had 5FU-induced mucositis, and the next time they gave them the same dose of 5FU, and they gave them an allopurinol mouthwash, and 3 of them didn't have any mucositis, and 3 of them had decreased mucositis, and they suggested it was helpful, and it started being used. Well, we did a placebo-controlled trial, and it was not helpful in that setting. But the next trial to do, I was talking to the nurses, and they suggested that we try cryotherapy since it seemed to help for head problems. And when we did that, we found out that the cryotherapy for 30 minutes decreased mucositis by 50%. There were guidelines on mucositis prevention, and initially the guidelines committee says, well, that wasn't placebo controlled, and therefore we can't recommend it. And I kind of said, well, how do you placebo control putting ice chips in your mouth versus not? Snow cone type ice chips, you replenish them over a total period of 30 minutes. And eventually they came around to approving it, because a lot of other studies suggested it. We then looked at 30 minutes versus 60 minutes, and 60 minutes was no better than 30 minutes in this particular setting. Onychomycosis, again, fingernail loss thing can be a big problem with docetaxel, paclitaxel sometimes too. Sometimes the fingernails just get black and all, but they don't fall off. First report in 2005, multiple subsequent reports, many of which are positive. And chemotherapy-induced peripheral neuropathy, we'll start talking about more here. The story starts in about 2010 in terms of rumors. And I know of that because I keep lists of things because I can't remember things and all that sort of thing. And I go back to my list, and I first heard about this in about 2010. People started talking about this maybe being helpful. And then the first published report that I have been able to see in this era was a review article written by some people from Denmark, ICOF, risk of docetaxel-induced peripheral neuropathy among 1,725 Danish patients with early-stage breast cancer. So they had looked at their population of patients. This was a retrospective review. They were conscientious about putting in the chart, in a particular part of the chart, everybody who got docetaxel, how much neuropathy they had after each dose of the duloxetine. And what they reported there was involving 1,725 Danish breast cancer patients. And the patients, they noted that the patients who used frozen gloves and socks, mainly for preventing nail toxicity, not for preventing neuropathy at that time, but they had a 44% reduction in subsequent neuropathy problems with a significant p-value. So this supported the thought that it would decrease neuropathy. So the first study that I saw particularly regarding neuropathy came out as an ASCO abstract in 2016, and it was published in 2017 by a group from Singapore, Dr. Sundar and colleagues, who looked at this particular situation. And they took patients with breast cancer who had been treated with weekly paclitaxel, 80 milligram per meter squared, a standard dose for at least 12 cycles. They gave them limb perfusion cryotherapy, given on the dominant hand and foot for 90 minutes. And the non-dominant side was an untreated control. Some people argue and say, oh, that's not the best design because maybe your treated side will do better than your dominant side will do better than the undominant side in terms of testing and that sort of thing. Yet this is a nice thing to have each person be their own control. And they use a monofilament test at baseline as their primary endpoint at the 12-week mark. They had 44 patients registered, 36 evaluable, and you'll see a number like this in other trials because that's a reasonable sort of pilot study situation. And these are the results of this study. And nobody dropped out from the cold. And the results shown here looks at deterioration at 12 cycles. So in the patients, looking at the monofilament test in the hands and feet, 75% of the patients in the control arm deteriorated, but only about 25% of the patients on the cryotherapy arm. And there was a neurotoxicity questionnaire, and again, similar numbers, about 25%, this time 19%, versus 67% worsened with significant p-values, suggesting that this, in fact, was a helpful sort of approach. So at Mayo, we did a pilot cryotherapy trial. We looked at patients. We published it here in 2019, and I'll show you some results here. We looked at 46 patients, similar number of patients, half and half getting cryotherapy versus control. The cryotherapy here was done in a simplistic sort of manner. For the hands, we took bags of ice and 2 bags of ice and put one on the down on the table there, and then another. Then the hand went on top of that bag of ice, and then another bag of ice went on the top of the hand. For the feet, you had a similar sort of situation. We used one of those old wash basins that you used to use in the sink. Put ice on the bottom and a bag of ice on top. If it got too cold, you took the top bag off. If it got too cold, you could lift your hand up a little bit to where it was tolerable for patients. And what we saw here is illustrated here. The change from baseline of average sensory subscale scores. This is the line of unity, so that there's just a 0 coming across here. This is the time during the treatment, and this is the time, the months after stopping treatment. And the cryotherapy arm is doing a little tiny bit better than the control arm, but this is not very impressive and not much to write home about. And it's kind of a negative-ish type trial, and we were somewhat disappointed. But then as we looked further at it, and this is going to be a complicated sort of slide, but I'll walk through it. We had done 2 similar trials before doing this trial, looking at minocycline because of suggestive benefit there, and looking at pregabalin. And in both of those trials, so that here's the yellow trial is the cryotherapy trial, and this is the control arm of the cryotherapy, the dotted one. The green one is the pregabalin and the control arm for that one. And the red one is the minocycline, the control arm of that one. And both control arms didn't do near as well as they did in our cryotherapy trial for one reason or another. As we is I adjusted things a little bit here and put all the control arms together. So all the control arms are in the blue here for all three of the arms. And here's the pregabalin and minocycline. It does look like the cryotherapy arm is doing a bit better than the other three arms. But again, not definitive evidence that it's doing better. There have been several other study reports. They're relatively small studies. Many of them have been positive, but not all of them. We could argue whether you consider my trial that we did at Mayo, is that positive or not, or somewhat in between. So which of the following modalities has been estimated in lieu of or in addition to cryotherapy to try to reduce neuropathy? Compression, electrical stimulation, cycling of hot and cold, ultrasound. Okay, so we got about two-thirds of participants who have picked the correct answer, and that is compression therapy. So the first report of that was presented at a San Antonio Breast Cancer Symposium in 2016 and published in Breast in 2019. And this was a group from Japan. And the thought process for why cryotherapy might be helpful is because it decreases blood flow to the scalp, into the mouth, into the hands for the different places where you're giving it for different chemotherapy drugs, and that you decrease in blood flow. And they said, what if you took a surgical glove, one size too small for the patient, and put two of them on? And would that decrease blood flow to the hand? Would that help neuropathy? So they did that on one hand. And on the other hand, they served as the control for that particular study. So two surgical gloves, on the other hand, served as control. Again, about 40 patients, 43 patients here in this particular trial. And if they looked at grade 2 sensory neuropathy or worse, 76% in the control arms and 57% in the gloved arms. And again, a lower number is better in this particular settings because you don't have grade 2 neuropathy. So a suggestion of some benefit, not quite as strong as maybe was seen with the cryotherapy, but the right direction. And if you looked at some other questionnaire results, grade 4 neuropathy was higher in the control hands than in the gloved hands. So then a group from Singapore, the same person led the initial cryotherapy trial, looked at what if we do both cryotherapy and compression? And this was an ASCO abstract in 2018. And they had 13 patients who underwent 142 cycles of cryocompression concomitant with chemotherapy. This was not a randomized trial. They had the skin temperature did reduce to this amount, and it was well tolerated. Only one patient needed a temperature increase. And there was a suggestion of benefit. And I don't remember if I showed it on the next slide or not. So there's a suggestion of benefit. And that suggestion was they actually looked at their patients in that particular trial. They compared them to the patients that they had given cryotherapy only to, or had placebo or served as a control group only to in their previous trial. And it looked like the cryocompression was doing a bit better than the other ones. But again, not a randomized trial. Now, Dr. Don Hirschman and colleagues, this was published in presented at San Antonio Breast Cancer Symposium this last year, did have a clinical trial done at Columbia University. And it was a randomized trial where they took patients getting taxane therapy, and they randomized them to get cryotherapy. And the cryotherapy were gloves, frozen gloves and socks. And I should make note that for ASCO guidelines, we oftentimes mention this otherwise, that some of the frozen gloves and socks have been taken off the market because occasionally people have gotten frostbite from them. So that's what they used for the cryotherapy. They used compression therapy with putting some tight process on there. And then they actually had a control group that got a very light glove on their hand, which caused minimal compression that they didn't think actually would cause any benefit or any harm, but that was to serve as control arm. And the end result of this particular trial, let's see if I have it next. So the end result of this particular trial was that The best arm in terms of how patients did was the compression arm. And the worst arm was actually the cryotherapy arm. And it was also actually not well tolerated, and somewhere around 3/4 of the patients could not tolerate the cryotherapy given that way for the whole process of things. And maybe in New York they're harder to tolerate things than in South Carolina, North Carolina, or in Minnesota. So there are a bunch of factors that support the use of cryocompression therapy. One is the magnitude of the clinical problem of chemotherapy-induced peripheral neuropathy, the promise of appearing early results that I discussed above, the absence of other established means of preventing chemotherapy neuropathy, and the data supporting the cryotherapy will decrease nail toxicity. All those reasons are potential big things or potential reasons for potentially using this in clinical practice. The factors that discourage the use of cryocompression therapy, the rare reports of frostbite, patient discomfort with the cryotherapy to varying degrees, logistical difficulties with providing this therapy for the patients and the families and the nursing staff and having to change things around. And if you have different gloves, the frozen gloves, they only last half the period, and you get to put others in the freezer and get the other ones. And the lack of definitive proof that this approach actually decreases chemotherapy-induced peripheral neuropathy. Now, there is a cooperative group protocol proposal that I've been involved with, and it recently got approved by the NCI in concept. And when a protocol is approved in concept by the NCI, in my experience, the protocol will be approved 100% of the time. So the hardest thing to do is get the concept approved, which recently was obtained. And this is involving people from a number of cooperative groups, including the SWOG group, which has taken the lead on this particular one. And also this alliance will participate, and the ACOSOT, another group, Deb Barton's group, is participating in this thing. And it's called the STOP CIPN trial. And this trial are for patients starting a taxane, weekly paclitaxel, or weekly paclitaxel plus carbo, or paclitaxel carboplatin every 3 weeks, or docetaxel carboplatin every 3 weeks for 6. I could not have prior neurocognitive chemotherapy. You could not have pre-existing neuropathy. They're randomized 1-to-1 to these 3 arms, which I'm going to discuss below here. The intervention happens on all 4 extremities. It starts 30 minutes before the taxane and continues until 30 minutes after. The cryocompression, the temperature is at 11 degrees centigrade, and there's some cyclical pressure with that, 5 to 15 millimeters of mercury. It seems like that cyclical pressure coming and goes seems to make the cold therapy more tolerable, and that's why those 2 things are together. Continuous compression with a pressure of 25 millimeters of mercury, and then a low cyclic compression. That's really the control arm with pressure of 0 to 5 millimeters of mercury every 5 minutes. And we don't expect that to change the chemotherapy neuropathy if, in fact, we hope that these other 2 will change, but we don't think this is, and this is the control arm of this particular trial. And the Paxman, who helps to make the hair alopecia prevention product, has developed this machine to make it user-friendly so that you can figure out, put in the dial how cold it gets and how much pressure it gets, and be able to tolerate that. If it's too cold for a patient, you can turn that temperature up a little bit. So the status of this particular protocol is approved by the SWOG Executive Committee. The FDA has determined that no device exemption is needed. The concept has been proved recently here. The protocol is being developed. Sites are being identified. There are about 25 sites that will participate in this trial. Each site will get 3 machines because if you're going to put patients on relatively quickly, and you might have 2 or 3 patients coming at a time, they might be on the same day as the others, so you have to have that number of machines. So if there's anybody listening that's interested in this process and wants to be a site, Dr. Accordino is the study chair. This is an email address, and email her and say, hey, I heard this crazy guy talking about it, and I'd like to participate in this trial if you're so interested. So why should we not just embrace what seems to work and not subject patients to a control arm, is what I'm going to talk about next here. And what can we learn about the story of calcium magnesium for oxaliplatinum chemotherapy neuropathy prevention trial? So we did a trial years ago looking at patients who were getting oxaliplatin, and there were data suggesting that calcium and magnesium given intravenously at the beginning and the end of therapy would be beneficial for decreasing neuropathy. And I'm going to show you some data in a bit as to how prominent that thought was that it would be helpful. But there are three arms. Two arms got the calcium magnesium before and afterwards. One arm got placebo before and afterwards, and the other arm got calcium magnesium before and then placebo at the end of their chemotherapy neuropathy. And there's no suggestion of any benefit whatsoever at all in this particular trial with 110 patients or so per study arm. So it's a negative trial. So let me go back to this one here. Because of our knowledge that it had been used so prominently, it took 10 years to get this figured out, we went back to a insurance base and looked at how often patients who were getting oxaliplatinum, and we knew these patients were on the insurance program for at least a month prior to starting their oxaliplatin chemotherapy, and they were on it through the whole period of their oxaliplatin chemotherapy they were getting. Also asked to see, did they also get charged for calcium and magnesium in that process so that we know that they got calcium magnesium therapy in addition to the oxaliplatin. And the results are shown here. Because of a study by Gamelin, a French person, back in the 2004, suggesting this was beneficial. When they did it, they thought it would be helpful. They did it in a few patients, and they looked back at a control group from 10 years earlier and says, hey, we're getting less neuropathy. Almost 50%, up to 45% of patients in the United States were getting calcium magnesium while they got oxaliplatin. And then there was a letter to the editor in JAMA, or in JCO, that suggested that actually it prevented chemotherapy benefit. And so it dropped off abruptly here. And then it became apparent later on that that letter was an error, and there really wasn't a loss of benefit, but there was some other reason, and I won't go into the detail of that now, but could be a question. And it came back to about 40% of people using it. And then when we presented our paper and published it, it went down to here, and right now it should be down to 0 and never been used. So it took 10 years to get that sorted out. So that goes to show it's worth proving that something is beneficial and finding the right way to do it before widely endorsing it. So in conclusions, chemotherapy neuropathy is a big problem. Nothing's been proven to prevent other than holding neurotoxic chemotherapy. Cryotherapy has been shown to work for other things. It looks promising for preventing CIPN. And let me go to, and all. Now, if I have patients, I'll say one other thing. If I have patients and a patient really wants to try this and all that sort of thing, I don't say that it's wrong for them to try doing the cryotherapy. But I think that what we really need to do is find out in a placebo-controlled manner whether this actually works. So let me stop, and if there are questions, I'm happy to address such.
Dr. Loprinzi, thank you so much. Let's see, I'm going to go ahead and advance this. I think I'm going to advance it. There we go. And so there's our Q&A, and then I do need to moderate that. So let me just pull that up. So this is a great time. You should, in your Poll Everywhere section, be able to see a place where you can go ahead and submit your questions. And I'm just looking for those questions to come in. Hopefully you'll be able to beat me to it, because I have a big list. So I'm hoping our audience doesn't have me monopolize the whole time. Dr. Loprinzi, maybe start off with talking about optimal temperature. So I was actually surprised at the 11 degree positive Celsius temperature there, which would, pretty warm, about 51 degrees Fahrenheit. How are researchers arriving at this optimal temperature, or do we think we have arrived at an optimal temperature?
So our colleagues in Singapore have done a lot of work in this particular area and all. They're trying to get to the lowest temperature that's tolerable for patients still, and they think that will be efficacious. So between, you don't want to cause frostbite, and all, but you want to get down as low as can be. So that's the best answer I can give you for that.
Gotcha. And of course, that's much warmer than ice would provide, than say chipped ice would provide. But that is at this point that 51 degree Fahrenheit, what they're thinking is probably optimal.
That's what it seems. So is that 51 degrees? Yeah, I actually hadn't put it into Fahrenheit temperatures, but that may well be. And if you have it the whole area, all that sort of thing, then it might get cooler in the middle or something. But
right. We do have questions coming in from our audience. First one, what about treatment of chemo-induced peripheral neuropathy? Is scrambler therapy a viable alternative to pharmacotherapy?
Yes. So treatment of chemotherapy-induced peripheral neuropathy. By ASCO guidelines, the one recommended drug is duloxetine. And it does work. More than one placebo-controlled trial has demonstrated that it works, but it does not work very well, and it's got side effects. So duloxetine is the recommended approach, and it takes patients, if they have 6 out of 10 problem, and you give them a placebo, it drops to 5 out of 10. And if you give them duloxetine, it drops to 4 out of 10. So it only drops by 1 point on the scale more than what a placebo does. So it's the one recommendation there. The scrambler therapy is one of the things that is out there as a recommendation for guidance of things that are reasonable to try but have not been absolutely proven. And also in that round is exercise. And I have seen amazing results with scrambler therapy. I've done some studies on it in the past, and I've seen amazing reports where it can be quite helpful for neuropathy. It has to be done by a group that knows how to do it. There are a couple of places in the country that are very, very good at it. And when people ask me about it, I give recommendations for a couple of places that you can contact. And one of the places will actually do a scrambler therapy is not just for chemotherapy neuropathy. It can be for other pain syndromes. And they will do a video consultation with the patient to talk about it before they even come there. They're situated up in New York area. And another place down in Florida. But I have seen that help. So next question, alopecia, mucositis, and mucositis are all local toxic effects. I realize you're not a neurophysiologist, but what is your understanding of the cytotoxicity causing CIPN? Does this support the hypothesis that reduced blood flow to the hands and feet from cryo or compression would be effective for CIPN? So the chemotherapy drug for hair loss gets to the hair follicles, and that's what causes the hair to fall out. So I think we all fairly well are comfortable with that. I'm talking about that first because that's easier than talking about the neuropathy thing. And so the thought process for why cryotherapy can help here is because you decrease blood flow when there's a lot of adriamycin in the blood, and less of it gets to the hair follicles. And after you take it off, if some of the adriamycin has gone away, whether it's metabolized by the liver or excreted by the kidneys, people know that better than I do, and all that sort of stuff. The other process, though, is also for the scalp cryotherapy is that if you cool the scalp, it may be less metabolically active, be in a more quiescent state, and therefore, even if some adriamycin gets there, they're not going to be trying to divide and make more hair grow at that time, and therefore, they won't be causing the problem there. So chemotherapy neuropathy, where exactly is the injury? Is it in the dorsal root ganglion, or is it where you do lose on your fingertips, you do lose nerve fibers from that, suggesting that some of the damage is from there. So that's the best answer I have for that particular one.
Great. I'm glad we had more of a question about the mechanism for that. I'm going to jump to this one because this was a question, what is scrambler therapy for those not familiar with that?
Yes. Scrambler therapy. So simplistically, everybody knows about TENS therapy, TENS, which is transient electrical nerve stimulation, which you have a little packet of things and you put 2 electrodes on. And the idea is that if in an area that has pain, if the gateway theory of pain relief, if you have pain in your hands, if you put sensation in that area thing and you're putting sensory signals into the brain, that closes the gateway so that pain signals can't get in there. And the biggest thing is when you smash your thumb with a hammer, what's the first thing you do? You shake your thumb, and then that seems to help the pain. So that pain, that's an electrical stimulation thing. So scrambler therapy uses electrical stimulation, but the person who developed it almost throws up if I try and say it's like TENS. So you have to be careful along that way. But it gives it electrical stimulation. It comes from a machine. There's a machine that looks like an EKG machine. It has 5 sets of electrodes. They're paired electrodes. And you put one, if the pain problem you have is right here, you put it here and here on either side of the pain. If the pain problem is way down here, you get a nerve that's going down to that area above that area, and you turn that on, and that causes some numbness, some tingling sort of process, and that, when it works, takes away the pain. So it has to be done in the office, and then you can put up to 5 leads on there, paired leads, so there are 10 things you put on. You put that on, and you do it for 30 minutes, and when it works, the pain can go away in a matter of minutes or so, and it can last for some time, and eventually the pain can go away for a complete period of time and may last for weeks that the pain has gone away. Some people may need to get other things afterwards. So if you look up scrambler therapy in the literature, there are like over 40 different reports that have been published in that area. Again, not as well integrated into practice, and you need people who know what they're doing for it. Dr. Tom Smith has done a lot of this work at Johns Hopkins.
Gotcha. Thank you for explaining that. I'm glad you said shake your thumb. I was going to say swear, but that's clearly not the right answer.
That might work too.
Okay. Is there a concern with cryotherapy compression that there is less effective cancer treatment or metastatic disease?
Great question. Great question. So let me step back to say people used to worry about that with scalp cryotherapy, and you can get metastasis to the scalp, and I've seen that from breast cancer. So it does occur. And so the thought process is you decrease that, you use chemotherapy there, you're going to get more of a problem there. The data that are available for non-hematologic malignancies, for some hematologic malignancies, it's recommended that scalp cryotherapy not be given because that's a problem. But for other ones like breast cancer and colon cancer, whatever, the incidence, and they look at it, doesn't seem to be any higher in people who got cryotherapy versus not. And so then if you think about chemotherapy, if you think about breast cancer or any of the other cancers, colon cancer were given for these treatments for neuropathy, oxide platinum and paclitaxel, they rarely go metastasize more distal than even the elbow. Is it possible to have metastasis in the hand? Yes, but that's the person might see that once in their career for the 35-year career, and I don't know that I ever did see that in my 35-year career seeing patients. So that's not a big area.
All right, thank you. How do you feel about alpha lipoic acid for chemo-induced peripheral neuropathy?
Yeah. Has been looked at. I believe that's on the list of things that are not recommended. The studies that have been done have not, again, no great big studies have been done, but the studies that have been done do not support that that's helpful.
All right. And do you have any thoughts, experience with patients using cryotherapy with oxaliplatin? Sounds like counterintuitive, but one study included patients on that.
Great question. Great question. So with oxaliplatin, it's a peculiar drug, and one of the most of what I talked about was chronic chemotherapy-induced peripheral neuropathy, which is numbness and tingling and pain that comes on slowly over time, or it comes on over time and doesn't go away. But with some drugs, you get acute neuropathy problem. And oxaliplatin is one of those things where you give the drug, and it can cause a lot of trouble with pain and mouth numbness and cold intolerance right as you're given the drug. So people said, no way could you give cryotherapy to the hands. They can't tolerate that problem, that thing. But in one study actually did do it, and there have been other reports where people have done it. And there have been people who have suggested that they've had positive results in patients getting oxaliplatin. So it's, again, one published study included patients with taxane or oxaliplatin. And they didn't particularly point out in that paper that there was more of a problem in patients getting oxaliplatin. So it seems to be not a problem, although that's a surprise to many.
All right. And what would you recommend as the primary efficacy endpoint for chemo-induced peripheral neuropathy prevention trial? And what is being used to stop a CIPN?
Yeah. So the most important endpoint for these trials are patient-reported outcomes, PROs. Having patients fill out questionnaires. How much neuropathy are you having? There's a number of different questionnaires that can be gotten along that way. The CIPN 20 instrument, which is a 20-item questionnaire, that's why CIPN 20, developed by the EORTC, a European group, is the one that I like best in there. They have 6 questions that are I think the best effective ones of the 20 questions, and they are: do you have numbness in your hands? Similar question about feet. Do you have, it's actually fingers and hands and then toes and feet. Do you have tingling in your fingers and hands? Another one, toes and feet. Do you have shooting burning pain, fingers and hands, even toes and feet? Those, and you look at those 6 questionnaires, you get the same answers if you look at the whole 20 questionnaires, 20 questions. And I think that that the biggest problem I have with that questionnaire is that I wish when they said that one about pain, it didn't say stinging, burning pain, because I've had patients that were on the scrambler therapy treatment, that were on that trial, and they said, I have pain, but it's not screening, it's not, I don't describe it as in that way. But that is the best way patient product. Better than, some people said you should get neurophysiologic tests and tech reflexes and all that sort of stuff. If you give the main thing is what the patient says is neuropathy is bothering them. If their ankle jerk doesn't work quite as well and that sort of thing. And usually it's the sensory problem that happens much more than the motor problems or reflex problems in that setting. So that's the most important part.
Great. Thank you so much to our audience for all of these wonderful questions. I've got just a couple of others. You mentioned the combination of the compression and the cryotherapy. Just imagining putting on 2 surgical gloves that would, in addition to compression, have a bit of an insulating or warming capability there. And then if you were to add a cooling factor around that, you'd be, to a certain extent, combating the warming of the insulation of the gloves. How do you mitigate that so that they're not offsetting one another?
You have Paxman build you a machine that provides the compression and the cooling.
Okay, great. So talk a little bit about that machine, because that was actually my next question. I'm, trying to envision something that maybe like some of these chair massagers might compress something. I'm imagining something that might cycle a cooled liquid through some sort of capillary mechanism. Is that the sort of thing we're talking about? What does this look like and work? How does it operate?
Okay, so it's by the people who developed one of the things for the scalp thing. Mm-hmm. And I showed a picture of it in there. If you go back in the slides there, and sure, you put a garment on, and you put them together by Velcro. I think I actually haven't seen one in person. I've seen a picture by Velcro, so it attaches to itself, and then by fluid you can put in pressure there. I think it's fluid as opposed to air. But either one could cause some compression, and then you can put having cooling processes in there too, and you can control both of those things. So that's how, and it's actually developed in a way where you can still be able to get an IV in. If you have an IV in the hand, you can open up that one part there, so you can do that process. So that's what it is. Again, I haven't seen them. But there's another company who years ago wanted to do something, and they developed something, and they wanted to come and show it to me, and they had cool liquid that went in from one place into the other and that sort of thing. And so I said, okay, I'll be a sample, I'll be a experiment, a guinea pig for it, try it on me, and it leaked all over the floor.
Oh my gosh.
So it takes some work to do it correctly, but that's where it is.
Right. And you mentioned that just were one to use some sort of a boots and gloves with some kind of a gel, that they don't stay at a temperature long enough to go throughout the treatment. I'd heard that some cancer centers actually maintain boots and gloves for patients at what they consider an optimal temperature. Is that something you've seen at all?
So there were frozen books and gloves that were around. Again, some got taken off the market because of some frostbite sort of thing. So I suspect, or it would not surprise me if somewhere between 25 to 75% of patients at some cancer centers got cryotherapy of some sort or another for taxanes. It would not surprise me. I don't know what those data are, but it would not surprise me. And people use it in different ways. And we did a low cost way of bags of ice and that sort of thing. You saw the results of our study, and it didn't work very well, maybe because the placebo arm did so well on that. So I think that places are doing it, and I guess if you could have somebody poll, if you could ask the question to the audience to quickly say, at your institution, is it being utilized? How many institutions are using this in practice for some of their patients? We might get interesting information. But
right. And in the last couple of minutes, if anyone wants to use that Q&A to weigh in on that, we'd love to hear from you. And we did have one question come in the last couple of minutes. Any recommendations for after the fact chemo-induced peripheral neuropathy treatment?
So this is treatment of established chemotherapy neuropathy. Is that what the question? So
I think they're meaning if you didn't, I'm interpreting this as if you didn't do anything during treatment, what mechanisms to after the fact?
Yeah. So so I focus primarily on prevention in this thing. The ASCO guidelines actually talk about treatment and that sort of thing. And one of the ASCO guidelines I recently gave were an update from the previous ones. And we didn't address what I'm about to say initially, but in this time we did, and say, if you're giving neurotoxic chemotherapy, paclitaxel for 12 cycles is your plan, weekly, 80 milligrams per year squared, and the patient is getting neuropathy after 5 or 6 or 7 weeks of this treatment, what should be done at that point in time? And we did not address that at all in the first time around, but this time we did do. And we basically said that we believe it's up to the physician to do some figuring in her or his head as to how much more the neuropathy is going to get worse, and how much additional benefit will you get if you continue the paclitaxel from just, let's say that they've had 8 cycles and you go to 12, and they're having significant neuropathy. Because if they continue to get more chemotherapy, they're going to get more neuropathy. And it doesn't go away after treatment's done, despite that one paclitaxel study where I showed it. It's interesting, oxaliplatin, well, after you stop paclitaxel, in the next 3 months on average, the neuropathy does get better. After you stop oxaliplatin, in the next 3 months after finishing it, the pain on average gets worse for 3 months. And it's called what's my word now? So it gets worse there. And there were people who said, the patient was doing fine while they're on oxaliplatin, and then in fact, once I stopped it, 3 months later, it was a lot worse. But when we looked at our data from studies, the slope of the list of the chemotherapy neuropathy that was coming around is the same in the 2 months prior to stopping the drug that it is in the 3 months afterwards. So it's just that, in my mind, the last dose takes 3 months to get fully, to cause the full neuropathy problem it does.
Understood.
So at any rate, but actually on that other situation, what you're supposed to do is recalculate how much benefit, and say, if we continue the chemotherapy, maybe we'll improve your chance of doing well by a couple of percentage points, but you have this neuropathy also, and then keep that in mind as to whether or not it's right to continue the neurotoxic chemotherapy, stop it, or decrease the dose.
Right. Okay. Well, thank you so much. I want to mention just a few other things in closing. We are at the hour here. There we go. So I want to say thank you to the state of North Carolina for their generous support of the University Cancer Research Fund and the UNC Lineberger Comprehensive Cancer Center. I want to thank the members of our team, Mary King, John Powell, Jason Paler, Veneranda Obore, Oliver Marth, and Andrew Dodgson for all of their hard work on each and every one of these lectures.